Hello and welcome to NTI. My name is Tracy and I'm a clinical specialist with Neuroptics. As a neuro-ICU nurse and educator with many years of experience using the NPI pupillometer, I'm honored to talk about pupillometry and the Neurological Pupil Index, the gold standard in critical care. During this session, we'll talk about the importance of using the pupillometer and NPI for accurate, reliable, and trendable pupil exams, and how current studies are supporting NPI as a means to detect cerebral insult, guide treatment, and inform patient prognosis. I know that we all do neuro exams on our patients. Depending on the patient, sometimes that exam can be difficult and time-consuming. But routine neurological examination is a best practice recommendation for all critically ill patients. And because pupillary changes are an early indicator of neurological change, an accurate and reliable pupil assessment is a critical part of our neuro exam. When we examine pupils, what are we really assessing? Here we see the brainstem with its three distinct areas, the midbrain, the pons, and the medulla oblongata. While the brainstem is important for many things, it also houses 12 pairs of cranial nerves. Pupil reactivity depends on the function of two of these cranial nerves. Cranial nerve number 2, the optic nerve, which originates just above the brainstem, and cranial nerve number 3, the oculomotor nerve, which originates in the midbrain, the top part of the brainstem. You can see that they lie superior to other cranial nerves in the pons and medulla oblongata that control reflexes such as swallowing, cough, and gag, along with heart rate, respirations, and other vital functions. Because of their location, cranial nerves 2 and 3 are very sensitive to pressure and other changes in the brain. And so a decline in pupil reactivity may be one of the earliest signs that the brain and brainstem are getting into trouble. Let's review how pupil constriction works. When light stimulates the optic nerve, cranial nerve number 2, the impulse crosses the optic chiasm, then loops around and through the midbrain via the oculomotor nerve, cranial nerve number 3. This motor nerve controls some eye movements, as well as the sphincter and dilator muscles of the iris, which control the amount of light allowed into the eye for optimal vision. Changes in size of the iris appear as dilation or constriction of the pupil. Unfortunately, factors such as small pupils, dark irises, and inconsistent sources of light with our flashlights and pen lights severely limit our ability to obtain an accurate and reliable pupil exam. Subjective terms like brisk, sluggish, and non-reactive are based on our best guess, with no standard definition, leading to high inter-examiner variability. Fortunately, we no longer have to guess at size and reactivity with pen lights, because we have the NPI pupillometer to give us objective and accurate pupil data. Inter-examiner variability was clearly demonstrated in this 2016 study of nearly 2,400 manual pupil assessments. 2 examiners, either MDs or RNs, performed an assessment on each patient. Then the patient was assessed with the NPI pupillometer. Researchers studied examiner agreement as well as pupillometer results. It is not surprising that agreement among practitioners for overall pupil assessment was low. A major finding was that practitioners agreed less than half the time about non-reactive pupils, and more than 66% of pupils scored as non-reactive by practitioners were actually reactive when measured by NPI pupillometry. Disagreement about non-reactive pupils can have significant consequences for the patient. This study concluded that NPI pupillometry could be a way to improve and standardize this important assessment. Today, more than 840 hospitals in the United States have adopted NPI pupillometry, including nearly 80% of the top 50 neurology and neurosurgery centers. Pediatric centers are also adopting NPI pupillometry for the same benefits and many of the indications we see in adults. So, what have these hospitals discovered, and why is NPI pupillometry so important? It's important because it helps us overcome the limitations of manual assessment, improve accuracy and reliability of the pupil exam, and standardize our care. Pupil assessment is standard of care for critically ill patients, and we need to get it right. We need to stop guessing at size and reactivity and use an NPI pupillometer to get it right every time. Some of you may already be familiar with the NPI pupillometer, a handheld, battery-operated device that delivers a consistent light stimulus and digitally analyzes the entire pupillary light reflex, from baseline through constriction to redilation. A patient-specific smart guard contains a memory chip that records and stores pupil data. The NPI pupillometer is very quick and easy to use. The smart guard is attached to the pupillometer and associated to a specific patient using the built-in barcode scanner. After positioning, the right or left button is used to scan the corresponding eye, then repeated for the opposite eye. Results are displayed on the device in about 3 seconds and can be uploaded to EMR using NPI Connect. I'm going to play a short video showing you how to use the NPI pupillometer.
To begin the measurement, position the NPI 300 with SmartGuard at a right angle to the patient's axis of vision, minimizing any tilting of the device. Position the foam pad resting on the patient's face at the base of the eye orbit. Remember, the pupillometer's right and left buttons are oriented to the patient's pupil being measured. Press and hold either the right or left button until the pupil is centered on the screen, and the display shows a green circle around the pupil. A green frame around the screen indicates the pupil is properly targeted, while a red frame indicates the pupil needs to be recentered on the screen before the measurement is initiated. Once the green frame appears, release the button, holding the pupillometer in place for approximately 3 seconds until the results screen is displayed. Repeat the scan procedure for the patient's other eye to complete the bilateral pupil exam. When the bilateral pupil exam is complete, the NPI 300 measurement results will be displayed in green for the right eye and in yellow for the left eye. Following the completion of the bilateral pupil exam, the NPI 300 is defaulted to Open Results Page 1, displaying pupil size measured to the hundredths of a millimeter, and the NPI reactivity values for each pupil.
As you saw on the video, the pupillometer defaults to Results Screen 1. The display is time and date stamped and shows results for the right eye in green, the left eye in yellow, and the difference between right and left eye measurements. Results Screen 1 shows size on the bottom row, displayed out to the 1/100ths for detection of unequal pupils, and NPI on the top row. NPI is the reactivity index, a numeric value that replaces our current subjective terminology of brisk or sluggish. NPI is a value calculated from all measured parameters. You can see them here on Results Screen 2. These parameters are run through an algorithm comparing your patient pupil data to a normative model, giving NPI as a result. To better understand NPI, let's look at this graph. Just as an EKG waveform has different components, the PR interval or the QRS complex, so does the pupillary light reflex. When we do a manual exam using a pen light or flashlight, we are making a subjective assessment of a small portion of the PLR, the constriction velocity phase, and we guess at whether it's brisk or sluggish. But to truly know whether a PLR is normal or abnormal, we need to look at the entire waveform and all of the components: the baseline pupil size, latency prior to constriction, constriction and max constriction velocity, the percentage of change between baseline and constriction, and dilation velocity back to baseline. All of these parameters are measured by the pupillometer and comprise the NPI. The Neurological Pupil Index, or NPI scale, ranges from 0 to 4.9. An NPI of 3.0 or greater indicates a normal pupillary light reflex, what we would traditionally call brisk, while an NPI less than 3 indicates an abnormal PLR, traditionally termed sluggish. An NPI of 0 indicates a pupil that is non-reactive, immeasurable, or atypical. There is tremendous benefit to having a number, the NPI, to trend over time just like other vital signs, instead of guessing that pupil reactivity is improving or worsening. Literature is showing us that an NPI less than 3, a rapidly declining NPI, or a left and right NPI difference of 0.7 or greater can be indicators of neurological change and deterioration. Let's talk a bit more about that NPI difference. This study reviewed data from an international registry. Researchers looked at over 54,000 pupillometry measurements from ICU patients with either stroke or TBI and correlated left and right NPI differential with modified Rankin score at discharge. As a reminder, modified Rankin scores range from 0 to 6, with higher numbers indicating greater disability and worse outcome. This study concluded that patients having even one NPI differential of 0.7 or greater had higher discharge modified Rankin scores and worse outcomes. The study firmly established a differential of 0.7 or greater as abnormal, even when occurring within a normal range of NPI of 3.0 or greater. So the concept of trending pupil reactivity is really important and just isn't possible with a pen light. Fortunately, the NPI pupillometer allows us to trend pupil data over time. The graph makes it easy to see NPI and size trends. On the left, we see normal trends in NPI and size for a patient over the first 12 hours. Then we see later where the patient shows a declining NPI trend along with increasing pupil size. This patient had increasing intracranial pressure, impacting the oculomotor nerve and affecting pupil size and reactivity. This demonstrates why it's so important to get a baseline pupillometer exam at the time of admission and continue to trend those exams over time. So, what types of patients can benefit from the use of NPI pupillometry? There are obvious primary neurological indications for use, such as TBI, stroke, seizure, neurosurgery patients, etc. But there are also many other conditions, surgical, cardiac, respiratory, and metabolic, that can lead to neurological problems. We call these secondary neurological indications. All of these patients, as well as those with a generalized altered mental status, require accurate pupillary assessment and can benefit from NPI pupillometry. The Neuroptics website hosts more than 130 clinical publications and abstracts speaking to the value of NPI pupillometry in a variety of primary and secondary neurological indications. As we reference studies supporting NPI pupillometry, we want to remind you that the NPI 300 has been approved for use by the FDA as an assessment tool to measure pupil size and reactivity, and it has not been approved by the FDA for diagnostic nor prognostic purposes. As with all medical devices, there are specific indications and contraindications for use, which you can review on the website. In addition to many studies that support NPI pupillometry for improved pupillary assessment, there are other consistent themes emerging from this body of literature. Several studies show a correlation between NPI and neurological decline. An NPI of less than 3 is associated with neuroworsening and may occur hours prior to clinical deterioration. This has been shown in numerous studies of patients with increased ICP, midline shift, stroke, TBI, and delirium after cardiac surgery. We all know how important it is to assess the effects of our interventions. Several studies report using NPI to assess treatment effectiveness. Improvement or normalization of NPI may be seen in patients treated for increased ICP and cerebral edema, TBI, stroke, and non-convulsive status epilepticus. Outcome studies are critical to our understanding of how well patients will recover from their illness. There are several outcome studies related to pupillometry showing that abnormal NPI and/or NPI differential correlates with worse clinical outcome in a variety of neurocritical care diagnoses and specifically traumatic brain injury. Abnormal NPI after cardiac arrest or ECMO also correlates with poor outcome. Many of our high acuity patients, regardless of diagnosis, are ventilated, sedated, and pharmacologically paralyzed. In addition to the potential effects these interventions have on oxygenation, they reduce our ability to do an effective neuroassessment by altering motor and verbal responses. Often in these patients, we are left with only cranial nerves to assess, including the pupils. Many nurses ask us how these medications affect NPI and if the pupillometer can or should be used on these patients. This graph shows how pupils are affected by many common ICU medications. In this case, we see the significant effect of remifentanil, on parameters such as pupil size and constriction velocity. Yet the overall NPI measurement of reactivity remains stable. Using a penlight or flashlight, it would be impossible to determine if pupillary change was related to the medication or to a true neurological change. That's why NPI is the only accurate and objective measurement of pupil reactivity in the presence of many common ICU medications. Several studies reveal similar findings. The one highlighted here showed that NPI remained stable and reliable even in the presence of common intoxicants, concluding that NPI pupillometry can be used as a tool for rapid neurological assessment of patients in the emergency department. Let's tie together some of the concepts we've been discussing by looking at a case study from the University of Pennsylvania. This patient is a 49-year-old male, status post-cardiac arrest. He has no known past medical history or allergies. He is obese with suspected cocaine use prior to collapsing while eating. His family started CPR and called 911. He had return of spontaneous circulation, or ROSC, after 20 minutes of CPR and 2 doses of epi. Once in the ED, they found vomit in his airway. He had runs of VTAC and hypotension and full body jerking. A major complication and frequent cause of death following cardiac arrest is anoxic brain injury. Even though this patient survived his cardiac arrest, there are a number of factors that might contribute to anoxic brain injury. The quality of CPR performed by the family, the 20-minute downtime, aspiration pneumonia, VTAC and hypotension, and full body jerking, which represented seizure. This patient was intubated for respiratory failure due to aspiration pneumonia and pulmonary edema. He was started on targeted temperature management and given a variety of medications to treat his refractory status epilepticus. He had advanced multimodality monitoring to include ICP and cerebral perfusion pressure, brain tissue oxygen, microdialysis, which is a monitoring of brain tissue chemistry to include elements such as glucose and lactate, and pupillometry was performed every 2 hours or more often as needed. Here is an epic screenshot of his neuroassessment. We first notice that he is sedated and not able to be assessed by typical neurological exam. At noon, we see a normal NPI, it's above 3.0, on both the right and left pupil. Even though his ICP is normal, we see brain tissue oxygen, cerebral blood flow, and microdialysis values that would indicate some tissue hypoxia and altered metabolism. 2 hours later, the exam is about the same, except that the NPIs are slightly lower. Look what happens at 1600. The right NPI has dropped to 0. Even though the ICP was stable, this drop in NPI prompted the medical team to do a CT scan which showed cerebral edema. The patient was treated with mannitol, and an hour later, the NPI recovered to baseline. This pattern repeated later in the evening when another decline in NPI, despite normal ICPs, prompted treatment with mannitol and a recovery of the NPI back to baseline. This case shows how this clinical team was comfortable using NPI as an early indicator of neurological decline and a guide for treatment. Ultimately, this patient had a good outcome. To get the most benefit out of this technology, we need to use it correctly and consistently. Using the pupillometer to spot check or double check a manual exam is not effective because we'll miss those subtle early changes that indicate neurological decline. So what's best practice? We need to use the pupillometer to establish a baseline assessment at the time of admission on any patient that has the potential for or actual neurological injury. Then continue to use the pupillometer for routine pupil examinations on patients for accurate and trendable assessment data. Use it any time you assess pupils. And finally, establishing clinical protocols for use of the pupillometer helps to ensure standardization of care. There are several very successful protocols in use across the country, and we can share those with you if you're interested in developing a protocol for your hospital. Global guidelines are embracing NPI and pupillometry because it makes a difference in patient care and outcomes. These published guidelines all recommend pupillometry and NPI for patient care and prediction of neurological outcome. The first is in the setting of stroke, and the remainder in the setting of post-cardiac arrest. In 2024, as part of the Trauma Quality Improvement Program, the American College of Surgeons released best practice guidelines for the management of traumatic brain injury. These guidelines state that pupillometry can facilitate a more accurate clinical assessment by providing an objective and reliable assessment of pupillary reactivity and an early warning sign. Quantitative pupillometry can assess reactivity even when opioids and other drugs make clinical assessment difficult. And pupillometry results can be directly entered into the patient's electronic medical record. With all of the scientific and clinical support behind it, it's easy to see how we can use NPI to help detect neurological decline, guide treatment, and inform prognosis. The NPI 300 pupillometer is definitively recognized as the gold standard for pupillary assessment. We invite you to follow us on social media and also check out the Neuroptics website, where you can find multiple resources, including videos and webinars in the Education tab, and the studies we discussed in the Evidence tab, where you can view all of the publications or filter your search. Or you can scan this QR code to find all of these same great resources. Thank you for attending, and more importantly, thank you for the amazing care you provide to our patients, their families, and our communities. Please take time to care for yourself and enjoy NTI.